Hello and welcome to Osteoporosis Canada's Fracture Liaison Service webinar. This is a series known as FLS Works. Today we're going to hear from Dr. Hilary Jaegar. And while people are signing on and getting ready, I'll just share an overview of the FLS website, FLS Hub website, located on the Osteoporosis Canada website. You can see there's lots of resources here. We have the hub, we have the health net, the map, and there's some tools and resources on that site. So please feel free to visit that and check out the toolkit. We use the a registry and maintain sites in Canada. We also send out a regular newsletter, and we're more than willing to support any sites who are hoping to start a new FLS with our free consultation services. If you have any troubles, please just send me a message on the chat box, and we will try and sort that out. In the meantime, Dr. Jaegar is ready and willing to present to us. And I was just going to read about an award that Dr. Jaegar has just been received. And I thought they said it so well that I couldn't give her a better introduction. So she was recently awarded an honorary fellow by the Royal College of Physicians and Surgeons of Canada. Following many years of stellar service as a military physician, both at home and abroad, Dr. Jaegar was named Canadian Armed Forces Surgeon General in 2004, the second and last woman to hold the post. Dr. Jaegar has been called upon time and again for her leadership skills in times of crisis. Hundreds of thousands of Canadians benefited from her service during her brigade's deployment to the Red River flood in spring of 1997 and the ice storm of Eastern Ontario and Quebec in 1998. As commanding officer and leader of hundreds, this human-guided missile did what was needed to be done in her various roles, says General Hilary, even if that should perturb from time to time her superiors, including me. Now in retirement, Dr. Jaegar continues her contributions to Canadian healthcare, including as a leader with Osteoporosis Canada and chair of the Health Technology Expert Panel Review, an advisory body to the Canadian Agency for Drugs and Technology in Health. Exemplifying her commitment to finding solutions through lifelong learning, she has also completed a master's degree in health economics. So we're very honored to have her here with us today. And going to get started here in just a second. So we have some attendees as well. So that's great. Welcome to Osteoporosis Canada's FLS Works webinar. Before we begin, I was just going to acknowledge that the land our offices are located in Toronto are on the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabeg, the Chippewa, the Haudenosaunee, and the Wendat people, and is now home to many diverse First Nations, Inuit, and Métis. We also acknowledge that Toronto is covered by Treaty 13 with the Mississaugas of the Credit. So we're going to get started. I'm going to turn the floor over to Hilary. We will save some time for questions at the end. Feel free to put your questions in the question box. And Hilary, I'm going to send it over to you.
Well, thanks, Luann, and thanks everybody who's joined us. I hope you'll find the next 35, 40 minutes or so is what I'm aiming to speak. I hope you'll find it interesting and most importantly, useful in your thinking and working about osteoporosis care in general and about advocacy or implementation for fracture liaison services in particular. I'm not in Toronto. I'm in Victoria, BC, so I'm going to say good morning. And I'm located on the traditional and unceded territory of the Lekwungen speaking peoples, known to those of us sort of in the more anglicized terms as the Esquimalt and Songhees nations. And it's a beautiful place indeed to live and play and work. I'm talking primarily today about ways you can phrase or explain to decision makers the economic and the business case for implementing fracture liaison services. So this is a supplement to and should go alongside compelling reasons that come from quality of patient care and clinical results, which we have ample data about that. But this is a little more to appeal to the harder nosed decision makers that you may encounter. So I'm going to ask Luann to advance my slides because I'm kind of technologically limited here. Working on an iPad for Zoom doesn't work terribly well with concurrent PowerPoint. So, Luann, can you go back one? It's just a couple of reminders, and I have a feeling that the audience listening right now is fully aware of this. It's a little bit of a case of preaching to the choir, but I'm also aware that this webinar gets archived and is accessible through the Osteoporosis Canada website. So not everybody might know these, but just to kind of put some context around the economic and business case things I'm talking about, here's a couple of reminders. Next slide, please, Luann. And this is sort of how costly, just in pure stark dollars and cents terms, how costly osteoporotic fractures are. This data comes from a paper by Jean-Éric Terride and his group out of McMaster University. Interestingly, it shows you how long it takes to compile this kind of data in the Canadian system. The data is from 2011, didn't get published until 2016 because it takes a long time to get access to the data and do the analysis. But all osteoporotic fractures, they estimate, cost Canadians $4.6 billion in 2011, of which the biggest chunk was acute care at $1.5 billion, or roughly a third of that. It represented almost 1 million acute care bed days, which is an awful lot of time in hospital, and a little over 200,000 emergency or same-day surgery visits. It's important to note that that's the most recent really roll-up of costs that we have. And of course, 10 years have passed since the 2011 data was collected. And since then, what we know is that the Canadian, and we know this from Statistics Canada, that the Canadian population has increased by a little over 9%, but the population over 65 has increased by almost a third. And in fact, if we go back through data that we obtained, Luann, thanks very much, and Diane, by working with CIHI, the Canadian Institute for Health Information, we did get as accurate as we could data between 2007 and 2020 on hip fractures. And in 2011, which is the same year that Terry was using for his costing figures, there were 27,500 hip fractures in Canada. And by last year, that number had increased to a little over 34,000. So there you see kind of the effect of the aging of the population and the increase in the over 65 population reflected in a really significant increase in the number of hip fractures. Next slide, please. So we're here on FLS Works seminar series, so there's no mystery about what intervention we're talking about in the fracture liaison service. And Diane, I don't know if she's online, but most of the people on this seminar have heard Diane Theriault speak at some point in their evolution. It's been a fairly painful process to come to the conclusion that a fracture liaison service, and we would emphasize that it has to meet the criteria as defined by Osteoporosis Canada, is the only thing that's been reliably demonstrated to prevent repeat fractures. And of course, it's not necessarily, not the fact that the service exists that prevents repeat fractures. It's that the function of the service, it acts to increase the proportion of fragility fracture patients who actually take appropriate osteoporosis medication. So it's the medication that prevents the repeat fractures, but people don't take the medication unless there's a fracture liaison service in place. And this isn't a new finding. The studies that demonstrate this demonstrate its clinical effectiveness, demonstrate its superiority to every other thing that's been tried, most of which are either broadly based educational programs or kind of passively targeted automated letter writing approaches. So the studies that demonstrate that FLS works better than these go back more than 10 years. So we've known this for 10 years. Apparently our health system is so resistant to change that despite great clinical evidence, we haven't implemented this thing that works in over a decade. Next slide, please. We'll talk a little bit about why that's so. But before we do that, I want to make sure that the audience understands a little bit about the kind of language that comes out when you read anything that has to do with a health economic analysis. And a lot of the studies that assess the effectiveness of fractional liaison services include at least a portion of it. Part of the discussion will concern their health economics. So it's worthwhile taking a step back and having a look at the very basics of what health economics looks at. Next slide, please. So you've got this new health technology, and when you see the technology, that doesn't necessarily mean that it's a high-tech gadget or even a gadget at all. It can be a change in the way you manage care, a change in processes internal to a hospital. It could be, in the case of mental health, it could be the implementation of comparing psychotherapy to like cognitive behavioral therapy to medication. So when I say technology, it doesn't have anything to do necessarily with your iPhone. It is any kind of intervention. So when you have a new way of doing things, you compare it to the way you're currently doing things, which is referred to in all the literature as usual care. And usual care is often kind of a mixed grab bag of a whole bunch of clinicians doing whatever it is they feel like doing at the time. Or sometimes there really is a laid down process, but both of those possibilities are lumped into the terminology of usual care. So you really compare, the usual care with the new way across two dimensions. How do they work? The new way can work better, it can work the same, or unfortunately, it sometimes doesn't work as well. And then you'd compare them across the cost dimension. The new way can cost more, which is extremely common. It can cost the same, or it can cost less. Next slide, please. You can demonstrate this kind of graphically using an x-axis and a y-axis. Everybody remembers way back in the high school math for x-axis and y-axis, where you have effectiveness on the x-axis and cost on the y-axis, and that divides into 4 quadrants. I've color-coded them. So you've got the cost more and works worse in the upper left. That's kind of a no-brainer. Why would you do that? You've got the cost less and works worse, which is an interesting place to be. And in developed countries, you don't spend a lot of time thinking about that. But if you're in a poor country and you're trying to free up resources to do something very important in healthcare, then you may want to look at what you're doing to see if you can save a few dollars by doing something a little bit less well and saving a lot of dollars. But luckily, we don't have to spend much time there. Up in the top right is where most health economic analysis and most hard health policy thinking is done, because new things tend to cost more and they work a little bit better. So then the hard questions are, how much more are you willing to pay for how much better healthcare? And this is expressed in the literature by terms such as, this intervention was cost effective by the usual willingness to pay. So that means that's code language for it costs more and it works a little bit better. And we think that it doesn't cost so much that you should reject it out of hand. Every country's health system has an implicit threshold to what they're willing to pay for how much better health. And it's a politically sensitive subject, and I don't know of anybody that actually sort of publishes it hard and fast. But you can reverse engineer that threshold by looking at the things that they have approved for public funding and that they have rejected for public funding, and go back through the literature to see what how cost effective they were deemed to be. You will see this expressed as a cost per quality. or what they call an incremental cost effectiveness ratio, which is really the same thing. A quality is a quality adjusted life year. So if something extends somebody's life in perfect health for 1 year, you gain 1 quality. But most of the time, most people aren't in perfect health, and most people who have health interventions really aren't in perfect health. So you're usually talking about fractions of a quality adjusted life year. We may have to come back to that later. I don't think that was terribly clear, but anyway, that is a commonplace. You have to pay more to get more. The lower right-hand quadrant in green, where it costs less and works better, that's a very important quadrant. It's kind of the holy grail of new technologies, and it's quite rare. And the key language you'll see in health economics papers or in health economics sections in clinical papers is that this is the dominant quadrant. So whenever something is phrased as a dominant intervention, that means it costs less and works better. And if you go on to the next slide, I've kind of translated this into more words. If you're in the upper left and it works less well and costs more, you definitely don't do it. We talked about the works less and costs less, try to save some money, but at the price of some clinical outcomes, not likely advisable, especially in a Canadian context. Works better and costs more is the it depends. How much are you willing to pay for a quality adjusted life year? And if it works better and costs less, which is quite rare, this is the dominant strategy, it's no brainer, you should definitely do this. So next slide. Where does FLS fit? And I've got some citations from a few papers. I'm sorry for the amount of verbiage on there, but the really important parts are highlighted in bolded green. And I mentioned how old the research is. This paper was published in 2008 from St. Michael's Hospital in Toronto. A team of researchers whose names may be familiar to some of you. So they're amongst the first centers in Canada that looked at this. And this is a combined inpatient, outpatient fracture liaison service. Of course, back then, the terminology, the 3-letter acronym FLS didn't exist. So that's why they call it an osteoporosis coordinator, but it is essentially, it is the same thing really. The FLS term came out of meetings in the International Osteoporosis Federation. And so some of us don't love the term FLS. I mean, liaison is kind of a funny word in the English language. It can mean a lot of things, and it doesn't roll off the tongue. But it's an internationally accepted term, and we're not going to change it, even though we may not think it's perfect. Anyway, this is essentially a very early Canadian example of an FLS that was evaluated. They found that managing 500 patients with fragility fractures decreased their number of hip fractures from 34 to 31. So decreased it by 3. And they found that it's a cost saving measure, even if the coordinator saw as few as 350 patients annually. And then in brackets in the next paragraph, a dominant strategy, reduce the incidence of future hip fractures and to save money, a dominant strategy. We knew this in 2008. Next slide, please. So out of a slightly different approach to a fracture liaison service, this one was an inpatient only hip, focused on patients who had already fractured a hip in Alberta. Increased rates of appropriate osteoporosis treatment. That is really the active ingredient in this whole thing. Dominated usual care. There's that important keyword, dominated. And then further on in the quotation, see a reduction in fractures, gains in life expectancy, and substantial cost savings. Published in 2009, only 1 year after the other one. So clear evidence of clinical benefit, clear evidence of financial benefit. We've known this for 12 years, which would kind of, in my colloquial brain, would equal a whiskey tango foxtrot moment, or WTF. You can, which is what the, and you can fill in the F. for yourselves is why are we still stuck where we're stuck? But we're trying very hard to get unstuck. Next slide, please. So it's not, other countries are doing a little bit better. And one of the things I think that characterize systems that do a little bit better is that they are more unitary than we are. They have more central decision making and less fragmentation in their authority. So McClellan et al. Are a group out of Glasgow, Scotland. And so it's the Scottish NHS who basically said that you will do this and you will implement a fracture liaison service. So they were quite early out of the box. And this paper that this quote comes from is an interesting analysis. It's based on 8 years of actual data, but cost savings modeled for 10 years. So it's like, it takes a little bit of unpicking to figure it out. But again, they found that there's an overall cost saving, FLS with a dominant strategy, and they did what we call sensitivity analyses. So in a economic model, you hold everything else constant and you vary something. So you sort of say, well, I think we had data for instance, what proportion of patients were started on osteoporosis medication, but what if we're a little bit wrong on that? So you'll change that parameter, maybe you'll increase it by 10% and decrease it by 10% and see what difference that makes to your cost effectiveness analysis. Similarly, you'll say, well, we think the provider can see this many patients in a year, but what if they only see 80% of that? What if they only see 70% of that? Or what if they see 110% of that? So you change that kind of parameter. So this is what they mean when they did sensitivity analyses. And in all of these sensitivity analyses, sometimes they found that it's not actually cost saving, but it was highly cost effective, as in you snuck up into that upper right-hand quadrant. It's probably important to note at some point, and I'll try to remember to reiterate it later, that throughput and what you pay the FLS coordinator are the most important things in the sensitivity analysis. So you have to be a bit efficient in your use of time. And you have probably seen, if you work in the business, you've seen models where everybody gets referred to a physician osteoporosis specialist that meets a certain, they try to refer all their fragility fracture patients to an osteoporosis specialist. That's what's going to be the cost effectiveness downfall of these models. That's point number one, because physician osteoporosis specialists are paid quite a lot per patient encounter, and much, much more than the nurse FLS coordinators are paid. Next slide. So the little, going back to our cost effectiveness plane, the two axes, effectiveness and cost, and that little dashed oval just shows that most of the time, under most circumstances, FLS does come out as a dominant strategy. Every once in a while, especially if you've hired, for instance, too many coordinators, or you really only need half a full-time equivalent and you hired somebody full-time, you're going to end up creeping up into the yellow quadrant. But across all of the research that's been published, most of the time it's a dominant strategy, and that's really what we have to remember. Next slide, please. So we'll take this back to the case of fracture liaison service in Canada. Again, next. We, thanks to Diane and Luann and some negotiation with the Canadian Institute for Health Information and a little bit of money from Osteoporosis Canada, because we had to pay for this data extraction. As I said earlier, we went back to 2007 and up to 2020 on the total number of hip fractures in Canada. So you can see it plotted there. I was interested that it makes a pretty good tight fit to a straight line. And where you see the equation on the slide, that is the equation that describes that line. So y equals 659.06x plus 25388. And x in this case is actually not the year and spelled out, but it's the year as measured from 2007 being 0. So 2009 would represent 2, and 2013 would be 6. But that's just a little bit of what you have to remember to program the Excel spreadsheet. That's all that is. So given that, you can use that if you want to project forward a few years to see where we might be in Canada, and I'll come to that in a few minutes. The other thing you see written on the chart is an R-squared value of 0.9758. Now, I don't know that we have any statisticians on the call. And I vaguely remember way back, I think it might have been grade 10 math, when we actually had to calculate R-squared manually, and it was brutal, but Excel does it for you just at the click of a button. So it's very easy to calculate R-squared. And what is R-squared? R-squared is really a measure of how well the data fits that line. So you can have the same equation out from 2 or 3 or infinite number of sets of data. And sometimes it describes what you really have very, very well, and sometimes it doesn't describe it at all well. R-squared can vary anywhere from 0, which means there's really no correlation. It's you might as well have aimed a shotgun, and it's the distribution of shotgun pellets around the line. And 1 is perfect, and 1 has never been seen in nature, right? One is theoretically unattainable. So to say it in words is that R-squared tells you how much of the change in the variable on the y-axis, which is the dependent variable, remember dependent and independent variable, is explained by the change on the x-axis, the independent variable. And this is 0.9758 is a phenomenally high R-squared. So it gives you a lot of confidence in using old data to predict what's going to happen in the future. That's really what that boils down to. Yeah, this is Canada as a whole. I've got the same thing done for every province in Canada. It won't surprise you, or it should kind of be intuitively comfortable that the smaller provinces don't have quite that tight of a fit. Prince Edward Island is probably the weakest, and that's just because blips of 1 or 2 hip fractures in a province like Prince Edward Island come out looking like a big deviation, whereas blips of 1 or 2 in Ontario are nothing. Really. So if you're interested in the situation in your own province, let Luann know or let me know, and we can fill in the information for you. Next slide. So if you project that forward based on that equation that we saw on the previous chart, we expect about 37,200 hip fractures in 2025 across the country, and about 40,500 hip fractures in 2030 across the country. Now, sort of in between setting out to get this data, and we've had a little bit of a blip of excess deaths in this country, as is every country around the world, from COVID. But as of mid-September in Canada, there have been 27,400 COVID deaths, and that's all ages. Yes, more elderly people are more prone to die of COVID than younger people, but that's still an overestimate of the deaths in elderly people. And it's compared to an 80+ population currently, or as of the last published thing I found from Statistics Canada of 1.66 million people over the age of 80. So if the denominator goes down by a tiny bit, that's not going to change things materially, we don't think. Next slide, please. So what this means when you talk to managers, and managers are all kind of concerned about their budget, and they view their budget in terms of baselines and changes to baseline. But they really have to be broken away from that way of thinking about budgets, because the baseline for fracture care isn't horizontal. The baseline for fracture care is going up at roughly the same rate as the overall number of fractures or hip fractures. And hip fractures are the biggest drivers of fracture care costs in hospital. So usual care isn't going to be status quo. Usual care is on an escalator. The only way to slow down or to change the slope of that escalator is with a fracture liaison service. If you keep on doing what we're doing, you're going to stay on where the red line is going. And if you implement FLS, you can actually bend it towards flat. And in those places like Glasgow, where they've been at this for more than 10 years, they have actually had that line start to decline. So you actually can reduce costs year over year, but it'll take you a while to get there. In the meantime, what you have to do really is start to bend the curve towards flat. Next slide. So I'm saying this with some degree of urgency because demographics really isn't on your side if you're a healthcare administrator or a healthcare payer, or frankly, a clinician looking after people with hip fractures. Overwhelmingly, it's a problem of people 85 and older. Yes, we look for FLSs look to capture fragility fractures in people a lot younger than that. But the ones who are going to come back with hip fractures and be the most costly to the system, who are going to have the most decline in function, who are going to need long-term care and who may die, are those 85 and older. And you see the ratio there, 2.5 to 3 times more likely than those in their mid 70s and early 80s, and about 10 times more likely than those in the 65 to 74 age category. So the Statistics Canada helpfully publishes projections, and they typically update them quarterly, actually, but their website can be a bit hard to plow through to find what you want, but it's interesting reading. And they'll have a low growth, a medium growth, and a high growth projection, so they kind of hedging their bets. But all that boiled down to, we mentioned before, we're about 1.6, a little over 1.6 million people over 80 in 2018. It's more than that now. And that's going up to at least 4 million by 2045. So 25 years from now, a rough doubling of the number of people over 80. That won't carry on forever. So that you may run into some people who are inclined to kind of wait it out and see if it can sort of wait for the wave to pass. Well, I'm part of that wave. The peak baby boom birth years were 1958 to 1963. I'm a 1959 baby. We're not going to hit our highest risk age for hip fractures for another 23 years. 23 years is a long time to hold on to your healthcare system by your fingernails. It's a long time to trust in doing the same thing over and over again and expecting different results, the definition of insanity. So just more fuel to the argument that implementing FLS is critically important if your health system is going to continue to function for the next 20 years or so. Next slide. I gave a bunch of thought to why this seems to, I'll say, fall on deaf ears. Everybody nods sagely and then and seems to understand and agrees that it's critically important. But of course, then it's not accurate to say nothing gets done, because things do get done. Some provinces are success stories. some local health systems are success stories, but it more often than not, you make a wonderful pitch. Everybody is really enthusiastic when they leave the meeting, and then nothing happens. And part of it is the papers are written by economists, health economists, usually in conjunction with clinicians. They are academics by and large. They work out of university centers. And then, of course, they're briefed to decision makers, and they kind of speak the same language, but it's similar enough that they think they speak the same language, but they really don't. Say economists talk about cost per quality adjusted life year. And this is a measure that's independent of scale. So if you have an intervention, a disease that affects 10 people, you can assess the cost per quality. And that would be quite cheap to implement, because no matter how much it costs, 10 people don't move the needle very much. But so that's moving it. What it costs overall is known as budget impact, and decision makers worry about budget impact a lot. Economists who write papers do not. So budget impact and scale matters a lot to decision makers. So something that's going to be implemented across a population or across 20% of the population is going to make them pay attention. Economists look at the result of a model that probably either went through a 10-year cycle or even sort of a lifespan cycle. And they kind of assume that we've come to the end easily, like you just get there. They roll up all the costs, and they don't consider the fact that some of those costs, the front end loading of a lot of the costs. So upfront costs matter more to decision makers than to economists. We've seen a lot about how savings is compared with usual care. Decision makers, we try to tell them this, but at the back of their mind, they're really thinking about compared to this year's budget and how it's going to play in the next year's business plan cycle and budget cycle. And everything for economists gets translated into dollars. And most things can get translated into dollars eventually, but it's not always that easy. And decision makers are balancing a lot of other things, bed days, OR time, staffing, wait lists, union contracts. The mix of your health human resources may or may not be correct for the new intervention. So there's a bunch more complicating factors for decision makers. So when you're making an advocacy pitch, it helps if you're able to turn the language of the economists that you get from the academic papers into examples that resonate in the language that matters for decision makers, if that makes any sense to you. So you have to kind of project away just from cost per quality and turn this into tangible things that may resonate more with them. Next slide, please. So that leads to this slide. What else does we projected 40,546 hip fractures in 2030 imply? So that's so rather than just talk about how many dollars that's going to cost to treat, you can also think about it as being almost 36,000 hip fixation surgeries. Not everybody who fractures a hip goes for surgery, only about 88% do. So that's why that's a different number. And of interest, that's 5,500 more than last year. So I don't know that our health system has that much spare capacity. Those hip fractures mean almost 500,000 hospital bed days, again, 76,000 more than last year. A whole bunch of transfers to another inpatient facility. Primarily, those are rehabilitation hospitals they're talking about there. Not every local health system has ready access to rehab hospitals. Sometimes that just means more days in the acute care hospital, depending on what province and what system you're in. And a lot of transfers to long-term care, where a significant fraction of hip fracture patients end up. And a whole lot more demand, didn't even try to quantify it for home care, because most provinces are strapped for home care resources now, and any increment over baseline is going to be a significant issue to fix. Next slide. So there's some of the sort of the things you're facing. What does it cost to implement an FLS? The salary and cost data comes from British Columbia. It may be somewhat different in your province. Most provinces probably a little bit less. The basic staff of a fracture liaison service is an RN. It may or may not be full-time depending on the patient load and the number of orthopedic surgeons and the type of FLS you choose to implement. But let's say for the sake of argument that it scales out to one full-time equivalent. They work best if they have admin support, not full-time. So that's why there's less than a full-time salary there for admin support. If you choose to save a few bucks there, what you'll end up with is a less efficient RN because they'll have to do the work themselves. And A, they probably won't be quite as good at it. And B, you'll be paying more per hour to have it done. So false economy there. You need to have a physician who's willing to act as the medical lead. That's what the $7,000 in the column is kind of a stipend, an honorarium to recognize that. Miscellaneous costs actually include the increased number of people who will be, I've used oral bisphosphonates as the baseline. So the provincial drug plan will have to pay a little bit more for bisphosphonates, but they're cheap. So the total cost is $155,000, and that's per year. How many FLSs do you need? Diane Ontario is probably the best resource to go to try and work that through. You can get a rough guess based on number of fragility fractures, but that in itself can be a difficult metric to access depending on where you are. Just as an example of scale, we think that you can do all of Prince Edward Island for one full-time equivalent nurse. There's a little bit of schlepping involved, but by and large, the center of gravity for healthcare and PEI is Charlottetown, and that's where you base the person probably. British Columbia, we think would need 32 fracture liaison services. I didn't try to estimate Ontario because the picture would get a bit muddied with the Ontario strategy. It's not completely, it's not as simple as taking your total number of fractures or hip fractures, depending on what kind of FLS you want to implement, and dividing by the number of patients you think your coordinator can see per year, because there's geographic spread to consider. And that kind of approach might work in Toronto or Montreal or Vancouver, but it's not probably going to work out well for Sudbury or Kenora. So you have to have a little bit of consideration for geographic spread and for where there's a concentration of orthopedic surgeons and where are the referral centers for hip fracture surgeries. So Diane's probably your best resource for helping you figure out how many FLSs you need, but that's kind of the ballpark. If you're not as small as PEI, and almost nobody is, then you're down in single digits. And if you're British Columbia, Quebec, Ontario, then you're in the tens. Next slide, please. So what does that get you in terms of averting fractures? And this is not an elegant, elaborate model that I created. This is stealing existing data from the St. Mike study that we know is based on how many hip fractures they averted. And the West Glasgow, the one from McClellan's paper in Scotland. And you don't quite break even in the first year. It costs you about $7,000 in the red to get through the first year, but that's the last year that you're not in the black. And over the first 10 years, of course, you spent that $155,000 for 10 years. You've averted 44 hip fractures. It's because it's not just 10 times 2.4. There's a compounding effect of each cohort that comes through every year. So it piles on top of that. So you've averted $2.7 million in healthcare spending for a net savings of 1.1. And this is only based on avoiding hip fractures. Along the way, you have also avoided wrist fractures, humerus fractures, probably vertebral fractures. So all of those cost savings are gravy on top of what we're showing here. Next slide. So a quick recap. You can read this as well as I am. I didn't talk much about this. If you have the chance to listen to somebody like Larry Fennell, fractures are debilitating to patients. They're painful. They take them out of daily life for a long period of time. They may or may not be able to rehabilitate to the point you were pre-fracture, and that depends on what kind of fracture you had and how old you were when you have it. And they're very costly. FLS is the most effective way to ensure that people who have a fragility fracture don't have a second fragility fracture or a third fragility fracture. In most contexts, FLS is a dominant strategy over what we're doing now, saves money and resources while improving outcomes. It'll more than pay for itself, even if we only consider the costs related to hip fractures. And delaying implementation because of the escalator we're on with the population and the number of people entering their most at-risk period of their lives, doing nothing is going to be increasingly costly over time. Next slide. And that's it. I'm open to questions or comments or any kind of interchange that you may have.
Hilary, it's Luann. I just had a question. When you talk about the 32 FLSs in BC, that probably includes 32 FTEs, and it might mean less actual sites with more staff per site. Is that right?
Yes, and it will vary, though. It's very difficult. Canada is always a challenging context for healthcare implementation. I hate reading papers from someplace like Brussels or like Belgium. You know, the whole country can be covered by something out of Brussels, which you can't do in BC. So in some cases, a busy downtown hospital may have enough volume and may have enough orthopedic surgeons to warrant more than one full-time equivalent. This is like the Toronto General Hospital, the St. Paul's in Vancouver. These are just examples of very busy tertiary care hospitals. But there are other places doing orthopedic care that may not warrant, and may not warrant more than sort of half an FTE. And when Diane could probably speak to, there's an FLS running out of Kentville, Nova Scotia. Don't know how big the hospital there is. I don't know how many orthopedic surgeons there are, but I'm pretty sure that's not a full-time equivalent there.
Yes, she worked 8.
And when the volume gets down below sort of at least a half-time equivalent, then it's going to get increasingly difficult to recruit somebody that wants to work that little and to have them work efficiently when you get down that low. So then you start saying, well, can you cover more than one site? And then you're going to start losing efficiency to travel time. So economy of scale in Canadian healthcare, unfortunately, still is a real thing. And, there may be things you can do with telehealth outreach, with remote connectivity. But I gotta say, it seems like the easiest FLSs to implement, at least at first, are those based on inpatient hip fractures. And just look at how quickly Alberta has rolled out from sort of one pilot to, they have 8 now, inpatient hip only FLSs. But that kind of speaks to people being on site, on location in the hospital. And still, when you get the kinds of places that might do a hip fracture every 2 weeks, Are you going to have, how do you get around that diseconomy of lack of scale, if you want, the tyranny of small volume stuff? Does that, Diane's saying something about, can you chime in, Diane? I saw her put something up on the chat, but
Diane, try speaking now. I'm not sure if she's got her mic on.
okay. Our FLS is only 80% here in Kentville and have about 7 to 8 orthopedic surgeons.
Okay, so Kentville does
Oh,
have,
Virginia's chimed in as well, so.
can you hear me?
Yep, I
Go
can hear
ahead.
you now.
So Kentville, you're correct. They only have a 0.8 FTE FLS RN, but that's not what they need. Based on the fracture volumes seen at the Valley Regional Hospital, they actually need a 1.2 FTE FLS RN. It's just that we never managed to get the budget to hire even a 1 FTE. So it's a 0.8 FTE. She works 4 days a week. And obviously, because the fracture volume is great at that hospital, that means that some of the fracture patients are unfortunately left behind.
Now, Diane I lived in the Valley I'm an Acadia grad as an undergrad. Kentville's not a big town. What is the population in Kentville? Maybe 12,000 people?
Yes,
Is
but
that,
it's
is that
the,
drawing from Yarmouth and Digby and
yes,
all
it
the way
is.
down the
So it's
valley?
drawing from Shelburne, Yarmouth, Digby, Annapolis. So it's covering, it's the orthopedic service for all of the western zone of Nova Scotia. So that's why at that hospital, based on the fracture volume that they see, they would need 1.2 FTE FLS nurse to do the job adequately.
Great. Well,
So
sorry, go ahead, Hilary.
I was just going to say, you really do have to look at each hospital's catchment area, their volume, the number of orthopedic surgeons, and get some help from people like Diane to scope out how how many FTEs you're really looking for to get your FLS set up for success. Because there's nothing kind of more unfair in my mind to have an FLS that only reaches half of the patients who fracture in your system. Because then you now have 2 classes of fracture patients, right? Those who were captured by the FLS and those who, for no reason, no fault of their own, and actually for no fault of the FLS itself, other than it's under-resourced, who are left to their own devices and who basically, are at a much higher likelihood of refracturing as a result. It's hard to justify that on an ethical or even, as we've seen, on an economic basis. Any other questions?
I see none in the chat box either. So thank you, Hilary, for that great overview and that combination of economics and FLS and the need for FLS implementation in Canada. And thanks, Diane, for chiming in and answering those questions. So on that note, I will say thank you and good morning to you in BC. And we'll put this on the archive webinar so others can benefit from this knowledge as well. Thank you, Hilary.
Thanks, everybody, for tuning in.